Hello. Allow me to present some pediatric issues related to allergy and COVID-19 and share with you some of the questions and concerns of parents during this pandemic. I have no disclosures. From the data we have so far, children are as likely as adults to become infected with SARS-CoV-2, but they are less likely to be symptomatic or develop severe symptoms. This means that children might not be tested for COVID-19 as frequently as adults, and their true incidence will be very difficult to estimate. Also, their ability to transmit infection remains a big problem as long as they have mild symptoms. So, what makes children less vulnerable to severe and/or fatal COVID-19? There are many assumptions recently published. On the top of the list comes the lower density and/or maturation and function, I mean the binding ability of the angiotensin converting enzyme 2 receptors in the lungs of children. Also, children have more active innate immune response, being challenged with many infections, vaccines, and adjuvants during the early years of life. Could it be that children have healthier respiratory tracts due to lower exposure to as much cigarette smoke and air pollution as adults? Or there is fewer underlying chronic health disorders in the pediatric age group? There is another assumption that children, especially before the age of 4, have constitutional high lymphocyte counts than adults. So could this be protective to some extent? And lastly comes the hypothetical influence for childhood vaccination, including the BCG. There is currently ongoing research in some centers to exploring the possibility that BCG may have an ameliorating effect on the morbidity and mortality of COVID-19 in some communities. What argues against this assumption is that some countries that include BCG in their compulsory immunization programs are still bombarded with high morbidity and mortality from COVID-19. So let's wait for the research to come out. Concerning the epidemiology, a series from China that involved more than 2,100 pediatric patients, of whom more than 730 were lab confirmed, showed that children of all ages seemed susceptible with no gender difference, but the manifestations were less severe than adults, being asymptomatic, mild, moderate, or even severe in some of them. But critical cases accounted for only 0.6% of the studied sample, and most of them were in the first year of life. A task force on COVID-19 from Italy revealed that among more than 1,600 cases of confirmed COVID-19, only 1.2% were below 18 years of age, and the case fatality rate was 0%. Data from the CDC in the US showed that children less than 1 year accounted for the highest percentage of hospitalization among pediatric age groups. As you can see, the blue part of the bar shows the hospitalization rate, and this was highest in infants below 1 year as compared to other pediatric age groups. And another report from the COVID-net of the CDC showed that those below 18 years of age had the lowest hospitalization rates due to COVID-19, although those below 4 had higher rates than those above. Concerning the clinical manifestations, fever, cough, and shortness of breath were the highest manifestations in pediatrics, the same as in adults, and GIT manifestations were encountered a lot, including nausea, vomiting, abdominal pain, and diarrhea. Cutaneous manifestations were reported in pediatric patients, and there is a case report of an 8-year-old Italian girl with confirmed SARS-CoV-2 infection who presented with an asymptomatic papillovesicular exanthem and mild cough. We had a case in our center that presented with the same rash. But what's more important is the pediatric multisystem inflammatory syndrome that is related to COVID-19. It is increasingly reported, more than 70 cases with 3 deaths. It resembles a typical Kawasaki disease or toxic shock syndrome. Most of the cases have fever, half of them have skin rash, organomegaly, or lymphadenopathy. And a big sector of them were tested negative by PCR swab for COVID-19, but they were in close contact with cases that tested positive. So could it be some sort of a post-infectious inflammatory syndrome rather than an actual infection? More cases are needed to validate this. So the question that we are bombarded with these days is, does my kid have coronavirus? With fears and unknowns surrounding the pandemic, every throat tickle, every nose drip or cough is suspected. It can be difficult to distinguish allergic symptoms from symptoms of COVID-19. But we have to remember that we are in spring and early summer, where there is increase in allergic symptoms and pollination. Sneezing and itching are common in allergic rhinitis, while fever, fatigue, and shortness of breath appear more in COVID-19. The next question is COVID-19 more prevalent in allergic children? From the data we have so far, asthmatic children do not appear to be at a higher risk to get COVID-19 infection. And wheeze doesn't appear to be a common symptom of COVID-19. The same applies to other allergies involving T2 inflammation, such as allergic rhinitis, urticaria, and atopic dermatitis. Data from hospitalized, critically ill children and adolescents at a tertiary care medical center in New York City revealed that asthma was prevalent, not less than 24% among those children, but none of them actually needed PICU admission. So, is there a protective role for atopy? There are many assumptions as well. Let's go through some of them. Is the atopic status favoring antiviral immunity, or could the higher proportion of activated eosinophils in allergy may play a protective role? More convincingly, epithelial cells of respiratory mucosa in allergic persons express less AC2 molecules, and that interleukin-3, which is a crucial cytokine for type 2 response, is negatively related to the AC2 expression. Also, in this sense, we would think that topical administration of anti-allergic therapies, including inhaled corticosteroids, may directly protect the patient's airway from viral spread. We really don't have answers to those questions yet, but with time, research will show the truth. So what about the stay-home effects? There are good news that school cancellation decreased exposure to upper respiratory viral infections and limited the pollen exposure in spring and early summer. And of course, with less cars on the road, less levels of outdoor air pollution are found. But on the other hand, there is greater exposure to indoor asthma triggers, including secondary tobacco smoke and indoor allergens such as molds, mice, and roaches. Staying home hindered physical activity, which is known to be beneficial in pediatric asthma. A study from Ljubljana Children's Hospital in Slovenia showed that during the months of March and April this year, asthma admissions and respiratory tract infection admissions were lower in their hospital, although the pollen counts were the same for this time of the year, but the nitrogen oxide level in the air was significantly lower. It could be that the lockdown really dropped the rate of pediatric asthma admissions, or maybe could reflect the fears of parents to take their children to hospitals and healthcare facilities in order not to get infected. So the next question is, should we modify our asthma control protocols during the COVID-19 pandemic? There is no evidence that medications, including bronchodilators, corticosteroids, or even antihistamines, can lead to increased risk of severe disease from SARS-CoV-2 infection. Therefore, asthmatic children should continue their maintenance therapy. And of course, proper asthma control can prevent unnecessary hospital visits. The GINA guideline clearly stated that systemic steroids, if required, should be given in asthma exacerbations during the COVID-19 pandemic, except for the use of nebulization. It is considered as a potential risk for aerosol generation and transmission of SARS-CoV-2 infection. If a child presents with asthma exacerbation, especially in healthcare settings, a meter-dose inhaler bispacer with a tightly fitted mask or dry powder inhaler is preferred over nebulization, except, of course, in life-threatening cases. Would systemic asthma therapy help? Levine et al. Recommended augmenting inhalation therapy in COVID-19 infected children with intravenous magnesium sulfate or systemic corticosteroids to prevent deterioration and hence requirement and/or duration of nebulization during life-threatening episodes. Especially that a Cochrane review previously concluded that treatment with intravenous magnesium sulfate in the ER reduced the odds of asthmatic children admission to hospital by 68%. What about allergen-specific immunotherapy? In non-infected or recovered individuals, interrupting subcutaneous or sublingual immunotherapy is not advised, especially that SLIT can be given at home. But preparedness of the allergy clinic is imperative to avoid cross-infections during SCIT. On the other hand, both SCIT and SLIT should be discontinued in symptomatic cases or those in contact with SARS-CoV-2 positive individuals. Can we do pulmonary function testing safely? Routine spirometry and peak flowmetry should better be avoided during the COVID-19 pandemic due to risk of transmission to healthcare staff or other children. But if these are essential for some reason, then full infection control should be followed as per the standard guidelines. What about the role of telemedicine? While social distancing is being encouraged, most asthma follow-up should be postponed or delayed or handled virtually. This can permit mild cases to get the supportive care they need without being exposed to severe cases. The compliance and inhalation technique can be checked and corrected through videos, and health education on asthma action plan can be provided to reduce non-urgent healthcare visits. About allergic rhinitis management in children, a position statement of the area IACI group came out, and we may extrapolate that children with COVID-19 infection can continue their intranasal corticosteroid therapy because there is no evidence that such therapy would suppress the immune system. And of course, more sneezing may cause more spreading of the virus in case we stopped treatment. Decreased smell function up to anosmia is a marker for SARS-CoV-2 infection, but data from children are scant. So we have to answer the parents' questions when they ask about this. Why don't my child, does my child have it, in spite he doesn't have anosmia? Concerning allergic conjunctivitis, members of the IACI working group on the management of ocular allergy during the pandemic agreed on using anti-allergic drugs as a first choice treatment, with the addition of topical corticosteroids as second choice. The use of systemic immunosuppressants or topical calcineurin inhibitors was not a consensual decision. Conjunctivitis may be a sign of COVID-19 prior to or after the onset of respiratory symptoms. We have to keep this in mind. In conclusion, the real burden of COVID-19 in children in terms of infection and or carrier state needs to be identified by screening at a wider scale. There is no need to interrupt the standard asthma or allergy care of our children during the pandemic, with very few exceptions. The impact of racial differences, diet variations, and pollution levels on the global rate of COVID-19 morbidity and mortality really needs to be investigated. Thank you very much indeed for your attention.